Hello, welcome to EASD TV. My name's Vivienne Parry, and in this session, we're going to be talking about what the future looks like for people living with diabetes after this, the 60th anniversary EASD. So, with me, people you may know well already, I suspect, Bastian Hauck from Dedoc, and along with Renza Scibilia, and Christian Collin from Denmark. Hello.
Hello.
So, I get an impression from this particular meeting of diabetes, particularly type 1, being on the cusp with us talking about prevention and screening with a really concrete future program. Also, the GLP-1 drugs just taking everything by storm. So therapeutically, it's looking very good. What would you say?
I'll start and say, I agree. It is such an incredibly exciting time to be living with diabetes, if you like. I feel like we are on the precipice of something very, very big, very, very exciting. If you are somewhere where we have access to that. I live in Australia.
And we'll go on to that. But I just want to touch on the prevention bit, because the prevention bit for type 1, I mean, prevention, of course, we know about in type 2, but it's the kind of public health measure. But with type 1, we are seriously talking about prevention. Now we have a new therapeutic, only obviously licensed in the US, teplizumab, which might delay onset. And does that make you excited for the future?
It does make me excited for the future. We're not quite there yet. We're not talking about prevention, neither in type 1 nor in type 2. When we're talking about prevention in type 2, we're talking about regression. When we're talking about prevention in type 1, for now, we're talking about delay, as you said. But I think we are very close to getting it to a point where that may change. That'll probably be another couple of years, and we've heard this 5-year mantra for decades, but we will eventually get there because science has advanced so quickly now, and especially with the genetic testings behind that, that is looking very promising indeed.
What did you feel?
Actually the same, that we are really moving in the right direction. There's been so many extremely nice things to see here, that we are moving forward very fast, and in some areas maybe faster than we actually could have imagined. The only thing that is my concern...
Thanks to Denmark.
Yeah, yes. We're going to do our best. But anyway, my only concern in this is that research is ahead, technology, insulins, everything is ahead. But how can the society and the communities actually follow this, the regulation? How can it follow this so they will get on level, as you said, but we don't have access to this.
Yes.
But
so
it's there,
we're talking a lot about delivery, implementation and access. Yeah. So even in very well-funded health systems, we are seeing inequitable access.
We always have. So I think that we need to be mindful of that all the time. Who does have access? But it goes back before the access bit. Who knows about these things? Who understands what the pathways are? So if we're talking about prevention of type 1 diabetes, who knows about the trials that are available? Because really that's currently the way in to these therapies and to the possibility of delaying onset of type 1. So there is a lot of need to do that real piece around community education so that people with diabetes, who often drive forward the way that anything happens in the diabetes world, how is it that we get people to know about them, to start advocating, start sharing information in their communities to really advance what's being done?
And we just had the COVID pandemic where it was very, very clear that the first thing you need to do is test. And even there we saw huge parts of the population resisting because of fear, because of sometimes the weirdest theories around. In type 1, where also everything starts with testing, there is no knowledge around this so far. There's very little conversation. There is here at EASD. But amongst the community, amongst people living with, ask the standard person living with diabetes on the street or a mother of a child about stage 1, 2, and 3 of type 1, you will look into blank faces. So there is a lot to do, even before the access part, in terms of very basic. Do you know about this? Do you know what this means? Do you know what this could do for you? And then dealing with the concerns, the fears, the worries and setting up screening programs and then setting up testing before it even gets to getting drugs into the market.
And the other thing, of course, is 50% of type 2 remains undiagnosed. So we've seen some very neat ideas here about how to screen in a affordable and accessible way. The one that there are two favorites of mine. One is putting your fingernails underneath an infrared light.
Do you get a manicure at the same time?
Yeah, I do hope so. So one's that, and the other one is reading out text, which uses AI to. I think they said they were 75% accuracy. I mean, nowhere near accurate enough to use yet as a screening tool, but interesting that these kind of methods may be usable and accessible for global use.
And perhaps more palatable as well.
Yes.
I think that there is a fear often around what is this screening going to involve physically for me or for my child or for my grandmother or whatever it might be. So
you're going to come and stab me.
Absolutely. Yes. So finding anything that's easier, that is closer to home, so people don't need to get in, travel for 8 hours to a hospital or whatever it might be. These are all the things that are really critically important. When you involve people with diabetes in these stages of development of things, you hear about how important it is to have things that are easily accessible and people have the appetite for these sorts of things. So that's very, I think, really
So it was
important.
interesting, we heard from Partha Carr, who's the clinical lead for type 1 diabetes in the UK. 93% of people living with type 1 in the UK now have CGM. And everybody says, ooh, did you find a gold mine? Where did you get the money for that? I thought the NHS was broken. But actually, the key to that was people living with type 1, who they were the driving force in pushing that forward and making those, reluctant clinicians much more, involved in making CGM available. So, the power of people living with diabetes is extraordinary. And
we
should
can be very
acknowledge that.
vocal.
Yes, you can be very...
And we will see that happening in the type 2 space as well, also for CGM. It's going to take work, it's going to take much cheaper products, but we'll see it coming. It's starting already.
And I know, Bastian, we've talked about this before, but there's, the advocacy tends to come from the type 1 community rather than type 2. But are you seeing that changing? Is that going to be something we see different in the future?
It is a lot harder to be a strong and vocal advocate if you are type 2. The stigma is tremendously high.
Yeah.
And although the numbers are so much higher, if you look at any platform in advocacy in the diabetes space, and if you compare the number of strong voices in the type 1 versus type 2, it seems like type 1 is the much larger problem, but it's not. It's exactly the other way around. But yes, we do see change. We see a change in the Dedoc community. We started to be almost exclusively type 1 15 years ago. We now have at least, and I'm not saying we're happy with that, but we're getting there. We see almost 20% of our community having type 2. That's still way too few, but it's actually very, very good if you compare to many, many others. So it is changing. And the stigma was there in type 1 10, 20, 30 years as well. And we managed to get... Well, not rid of it. We still have
a lot of stigma in type 1.
A lot to do.
But it is worse in type 2.
But it has been gotten better. We will be working for and with, not on behalf of, but with the type 2 community. And we will in part be using the power of advocacy that we have built in type 1 to help support the other community, our friends who live with a very similar condition, but it is so much harder.
So we've talked a bit about access in health systems that are, by global standards, well funded, but there is a huge issue in making care available to the entire globe. And there's an absolute explosion of diabetes in some countries. I mean, we were talking here in the studio with representatives from Pakistan, and they have a 40% rate, 40%. And that's I can't remember the figures exactly, but it's tens of millions of people. So how do we deal with that? Because that's going to be a future problem of enormous magnitude.
Just coming back to the economical part and the calculation on who should have access to what. And again, I do agree with the type 2. It's much more stigmatized than the type 1. But the calculation is very often made very short, saying we have a price of a device, instead of thinking of what can you prevent by doing this, by changing your lifestyle. When we have both the GLP-1 and we have the CGM in combination, these two can help you immediately, and afterwards they can help you change your lifestyle and actually challenge you on how to live your life, and you can see the improvements in front of you. But the calculation is only the CGM or the GLP-1 and say, oh, it's way too expensive, but it will save you a lot of money in the end. In some business, they call it run to fail instead of preventive action. So then you cope with the problem once it pops up.
Yeah, and I mean, we need to be very mindful when we're talking about lifestyle, of course, as well, because there is so much that goes far beyond that people simply can't control. Non-modifiable risk factors are very, very real, but we have these therapies that are available to support people living with type 2 diabetes, living with obesity. These are health conditions that deserve the therapies that are available to them, without stigma, without fingers being pointed at them and blame. But again, all of these things, they're only available in certain places. They are not going to be widely available in Pakistan, for example.
Yes, and we need to think about what can be changed for entire countries.
Absolutely.
And I mean, there are the genetic risk factors and the non-modifiable risk factors. There's also, I spend a lot of time, 50% of my time in Copenhagen in Denmark. Yeah. And when I'm in Denmark and I think about type 2, Copenhagen specifically seems such a, remarkable, healthy, everybody seems to be very fit, very blonde, very blue-eyed, taking their bikes, and then you have this lifestyle, and you almost feel like that is probably not a problem in this country, but then actually you leave the capital, you go a little bit more to the rural areas, and you see, well, actually, that's Copenhagen, that's not Denmark. What I'm trying to say is Denmark is one of the richest countries in Europe. And there you can see that there's a lot of correlation also between type 2 prevalence, income, society, education, etc. We need to be thinking about all these things when we look at the type 2 pandemic in other countries where there is no biking system, there is no education system, there is no healthcare system that works as great as it does here. And coming back to the screening on the type 2 part, we did one of the largest screening campaigns for non-diagnosed people with type 2 in Germany in 2015, where we screened 1 million people simply by filling out the Find Risk test. That's 10 multiple choice questions. But then we asked those that were on the higher risk profile to go into a pharmacy, and we had 20,000 pharmacies working with us on World Diabetes Day, offering a free test. But it was a bloody, prick your finger. That is a barrier. That is a huge barrier. That is where new technologies and AI, etc., could move in. So we still want to start with something as easy as the Find Risk test, because that is, you can put it out on every single mobile. That's how we reached 1 million people in a single day in Germany, and we have 2 million people with non-diagnosed diabetes in Germany. If we have 40 million people in India and Pakistan, filling out 10 questions is easy. And if the second step doesn't necessarily need to be go to a pharmacy and prick your finger, but is something that is as accessible, that's something you could do over the phone, we're getting there. And then we have to think about the kinds of interventions that we could do that do not require millions and millions of investment, but they do require information, communication, peer support. That is something that we can deliver without a healthcare system, without billions to be put into infrastructure, and also maybe all for the poorest of the poor, because knowledge is something that can almost be for free.
One of the things that's clear is that these new therapeutics are creating a future for people living with diabetes, which does not have the kind of complications that were present in the past. I mean, when you're talking about
that are present today.
Yes, that present today, but the whole range of heart failure and kidney disease and all of those kind of things, and perhaps even things like dementia, Parkinson's, a whole range of other things as well. So the future is looking brighter there. I
really wish we talked about that more, because we still hear the scare tactics I mean, I think this is something that is absolutely appalling. That, for example, if we want to talk about a diabetes complication, we start with the scare story. And that fear arousal doesn't work. It simply doesn't work. There are so many.
It's so often not true now.
And it's not true. Exactly right. And yet we're still stuck in this communication idea and these campaigns that didn't work in the 80s and 90s, but hey, that's what we did. We're going to keep rolling them out. Whereas these, exactly what you've said, the risks for retinopathy, the risks for neuropathy, for any of these complications that we were told about at diagnosis. I can still remember from 26 years ago being scared beyond belief. Those stats haven't been updated. If you have access to these therapies that are available, the technologies that are available today, your outcome is likely to be very, very different. And yet we still communicated about it the same way as in 1998 when I was diagnosed.
And I love what Christian was saying about the economic argument, the health economic argument when it comes to talking to policymakers, that if you talk about the cost and the benefit, then maybe that becomes a better conversation that makes people understand that it is worth investing.
The trouble is with lots of governments,
they don't care what's happening in 20 years' time.
In 20 years' time, they're not going to be in power. Somebody else is paying for it. Anyway, a final thought from each of you about, just a brief one, about what you feel the future for people living with diabetes is following this 60th anniversary EASD.
I really feel calm, and I'm convinced that we will move in the right direction, and it's going to go even more faster. Again, my concern is the economical part, and walking around here is like being in a dream world, saying, yes, this and this as well, this is fantastic, wow. When you step out, it's like, here you walk around subject matter experts, people that have passion and really care about this. Once you walk outside, that's dangerous. It's like, you're going to die.
It's like the bit in Wizard of Oz, isn't it, where you suddenly go from grey to Technicolor, except it's going the other way.
Yeah. So important work to actually spread the rumors on how far we are. And again, the calculation, the problem is when government is only there for 4 years, they will only make calculation that will benefit them for 4 years.
Yes.
But this one is going to be way in the future and good for health.
Bastian.
I am very positive when I'm here at EASD. I'm very positive when I'm in Copenhagen because it feels like we could get there. When I look at the Dedoc community, more than 50% of our scholars are living in Africa, in India, in Pakistan. I think the long-term future for people living with diabetes will be bright, but I think we haven't reached the climax. I think in type 1, we're getting to things could get better sooner rather than later. In type 2, I think we're still in for a long, long time of this is not good. And we haven't even seen the worst yet. And then the future is yet to come.
Renza.
Well, Vivienne, the future is community, because all of these things, the way we progress it is we progress it with community driving it and powering it. So absolutely, the developments are happening by brilliant researchers, brilliant clinicians, and that's very, very important. But the way that we get these things funded, that we get access, that's where the community is. So I have so much hope for those Dedoc voices who are driving that across the globe, including the 50% from low to middle income countries who are just doing an incredible job of really advancing what is available to people in their communities. So always the future is community. It's always about community.
Fabulous. So the future is community. Thank you to all of you. And you'll be hearing from EASD TV very soon in one more moment. Bye for now.